Right now, I'd like to turn to Monisha from USAID for her opening comments.
Well, good morning and good afternoon to everyone. Thank you so much for the opportunity to present today. I know many of us are really busy getting pulled into COVID response, and so really appreciate everyone's time to take a step back and think about how important health systems and primary health care and value-based care really are, even in times of crisis like this. And so by way of background, I'm Monisha, and I'm a market access advisor at the Center for Innovation and Impact in the Global Health Bureau at USAID. I've been there about a year and a half now and come from management consulting and global health and economics background. For those of you who are not familiar with CII, our team it applies innovative and business-minded approaches to accelerate the development, introduction, and scale up of global health innovation. And so we do that through three main ways. The first is catalyzing innovation, so sourcing new ideas and new innovations. And so we've partnered with Duke and the Innovations in Healthcare team to support our Grand Challenges programs like Saving Lives at Birth. And we also not only source new innovations, but also then support them to scale, which, as Sunil mentioned earlier, can often be more challenging. And also thinking about how to strengthen innovation capacity within USAID. In the second bucket, scaling for impact, we use strategic planning, market shaping, and increasingly more innovative financing tools to introduce and scale up innovations. And finally, for strengthening cross-cutting enablers, our team focuses on digital health, public goods, partnerships, and human-centered design. I'm being told that you're not able to hear me, so I'm just going to switch to a different audio. Just give me 1 second. I apologize. And strengthening cross-cutting enablers. Is my audio okay now?
I can hear you just fine now. I think
okay,
that level of proximity helps.
I'm just getting some messages from others who sound like they're not able to hear. Okay, I'll keep going and let me know if there's still trouble, and I will try the Zoom audio again. Great, so if we could go to the next slide. So for today's presentation, I'm going to focus on value-based care, and I can keep this short given how incredible the presentations from Possible and Medica Santa Carmen were that already highlighted the principles of value-based care that we're exploring. So at CII, we've been thinking about how to apply value-based care principles in low and middle income countries. And as most of you know, this has been a popular concept in higher income countries in the US and in Europe, but is just now starting to be applied in lower or middle income countries. So we partnered with the GDI, the Global Development Incubator, which has a initiative called Leapfrog to Value that did a landscape report on value-based care in LMICs, along with support from the Gates Foundation and the Rockefeller Foundation. And so if we could go to the next slide. The impetus for this, as you all know, is we're starting to see poor quality of care driving mortality. The Margaret Crook's work in the Lancet Quality Commission showed that poor quality of care actually now drives more mortality than lack of access to care. And that's increasingly important as we're seeing the rise of chronic and non-communicable diseases where quality of care is crucial. And we're also seeing subsequently increasing costs. And part of this could be due to a volume-focused system where the health system measures and delivers and rewards care based on the volume or quantity of services delivered and not all on quality. And that's true both in the private sector that has often fee-for-service models that can incentivize quantity, and even in the public sector that often focuses on coverage rates or access, and not always with increasing importance, or not always with the same importance to quality. And I know that's changing now with a lot of efforts around quality improvement that groups like Medica Santa Carmen and Possible are already leading the way on. And we're seeing a lot of low and middle income countries move towards universal health coverage and really making big investments in upgrading primary healthcare. In India, as Sunil mentioned, the government is investing in national health insurance for the first time, really, and upgrading the primary healthcare centers to health and wellness centers. And so we see big opportunities for countries to really take a value-based care approach as they are making big investments in their health systems. If we could go to the next slide. Great, and so this is just posing this question of, as LMICs are increasing their health spend per capita, are they going to get the health outcomes that they want? Are they going to follow the trajectory of some of the higher income countries that we've seen that even with high health spend are not getting the same health outcomes that we would want, given that 20 to 40% of healthcare is often wasted with inefficiency, and we're seeing 5 million avertable deaths per year due to low quality of care, according to the Lancet Commission. If we could go to the next slide. And so as others on this panel have already highlighted, value-based care is an alternative model or framework really, that just aligns patients, providers, and payers around achieving high quality healthcare and the best outcomes for the resources invested. And for us, we really put measuring value at the center and focusing on a continuous cycle of innovation to drive that value. If we could go to the next slide. And so similar to what others have already said on this panel, the way that we had the framework that we had used to define value-based care is really putting measurement at the North Star and measuring value in terms of outcomes and costs, and then using that data to deliver care and to learn and improve performance continuously, and finally to incentivize that continued improvement. And so I can just walk through kind of an example and a few of the best practices that we had compiled for experimenting with value-based care. If we could go to the next slide. I know Possible and Medica Santa Carmen are already applying these principles, and their examples were excellent. But one of the report that I mentioned earlier highlights a lot of the innovators who are already applying value-based care principles in LMIC settings. And so one of them that you might be familiar with is Jacaranda, a maternity care provider in Nairobi that's applying some of these value-based care models in their clinics, in hospitals. And so in terms of measuring outcomes, it's not only measuring the clinical outcomes of mortality and morbidity, but also the patient-reported outcomes, or PROMs, of thinking about their holistic well-being and satisfaction. So groups like IiH, the International Consortium for Health Outcomes Measurement, have created these standardized metrics that do need to be adopted for lower income settings, but provide a starting point for what could be standard metrics to collect that include well-being and satisfaction. And so for maternity, for example, includes things like satisfaction with care, respectful care, ability to breastfeed, or anything else that a mother might care about beyond just the mortality and morbidity metrics that we tend to focus on. And then using that's the measurement piece. On the delivery side, creating a bundle of services that span that 1,000 days from conception to the first few years of life, and looking at that value data and continuously and adapting delivery of care. And finally, moving away from a fee-for-service model for each individual intervention that might happen throughout pregnancy and delivery, but more moving towards a bundled payment for an episode of care, which covers that full 1,000 days, and providing more financial and non-financial recognition for those providers who are able to achieve value. Next slide. So I'll just quickly go through this, as most of you are already familiar with it, but again, we are thinking about measurement in terms of tracking outcomes that matter to patients, integrating biomedical and non-biomedical data, and looking at that data longitudinally for an episode of care, and finally making it really user-friendly for providers to actually adapt care accordingly. Next slide. On the delivery side, focusing on creating these iterative loops of learning and improvement, and emphasizing prevention and more community-based or primary care-based care, which can often have bigger impacts on outcome, and designing that care pathway around a patient journey, especially if they're going to different providers across different care settings, and how do you create a coordinated continuum of care. And finally, next slide. Finally, on the rewards or payment side, is moving away from these fee-for-service or volume-based payments towards models that reward higher value care, and especially quality of care, and risk adjusting so that we're still ensuring that providers are caring for the most vulnerable populations. Next slide. And I mentioned this already, but we do think that there's a narrow window of opportunity as LMICs are starting to move towards universal health coverage and really making big investments in data systems, infrastructure and capabilities, and putting in place new financing models. Next slide. And the last thing that I'll leave you with is, at USAID, we supported putting out this report, but as a next step, we understand that not all countries are ready to use value-based care models, and there are varying levels of health needs and systems and capabilities. And so as a next step, we really want to focus on experimentation and supporting pilots where we can apply these value-based care principles. And so we're starting to look at 2 pilots in India on primary care, one in TB and one in COPD, that are focused on applying these value-based care approaches, and look forward to collaborating with many of you to see where there are other opportunities to apply these principles and test more locally and learn from that to help support scaling them up. So the next slide just has a list of the collaborators, but I can stop here. Thank you again, and hopefully you were all able to hear at least part of that.
Great, thanks very much. Actually, we really appreciate your effort with the microphone. You came through very clearly and certainly had a lot to present, Monisha, so we appreciate it. We do have a bit of time for discussion now, both among the panel and with questions. And I encourage you all, if you haven't done it already, to submit questions at the Q&A tab at the bottom of the Zoom window. And we'll get to as many of those as we can. I just want to start off with one, kind of recapping what we've heard from each of you. You all emphasize the need for new kinds of capabilities in your care models, and those include data. They include data that's turned into measures that actually matter for quality of care and that matter to patients. They include investments in new kinds of care teams. Wondering if you all can say a little bit more about how much we know about the level of investment or capital, the financial resources, the time and effort resources needed to make these models go. Sunil, maybe I'll start with you, since you emphasized getting to kind of a reproducible model, but one that still sounds like requires some upfront investment to make it work.
Yes, Mark. Can you hear me?
Yes, that's great.
Oh, great, perfect. There are obviously challenges to everything that I think all of us panelists have mentioned in terms of implementing and getting to scale. The investments upfront, whether it's in time or money, etc., in some ways are almost the easy part of it, because all of us bring a certain level of resources to bear in our different initiatives that we do. The challenges come, like in most of our cases that you've heard about here today. The key is, again, in getting scale, working with government. Well, that sounds wonderful, and it in fact is essential as a way to scale, but actually implementing it and getting results isn't easy. Governments by their very nature are bureaucratic, and when you look at developing countries, they tend to be perhaps more bureaucratic than most. There are corruption issues. There are change of government issues. When you start working with the state government and then there's an election and someone new comes in, well, in some ways you almost have to start again from scratch. There are issues of transfers of bureaucrats, etc. So one has to learn how to navigate all of this. So when you go into one of these initiatives, in some way the healthcare part, innovating, etc., is just one part of the battle. The second part of the battle is really understanding at a deep level what it takes to operate in close partnership with government, with other key NGOs, in delivering, the quality of the care, the value-based care that we want to deliver. Speaking of cost, I think the other point I would mention is right now, by and large, there are a lot of really interesting, both social entrepreneurs as well as NGOs, nonprofit organizations, working in many aspects of innovations in primary healthcare delivery. What strikes me is that we could all be so much more effective if we could find ways to align, to build coalitions, to work together at different levels. So one is the technology level, where many of the innovations or the delivery models that we're working on, I think we could learn a lot from each other and come up with more effective and cost-efficient delivery models. Beyond that, also, I think we can have more of an impact at a policy level in working with government if we operate as a group. We can work more effectively at in terms of doing program management with government as we work as a coalition. So that's the other thing I would encourage us to think about, not only as individual organizations, but particularly to organizations like Innovations in Healthcare, Krishna, because you work with so many people, as do you, Mark. Similarly at USAID, Monisha, through CII. So if there's a way to pull together coalitions of people, I think we all become more effective at all levels, from a quality standpoint, a cost standpoint, and an access standpoint in delivering the care that we want.
Thank you. Comments from others?
Sunil, I wish I could say that the investments were the easy part. For me, this is the biggest challenge. But having said that, I do agree that it's hard to do, it's hard to work in close partnership with many entities. But if we are able to increase the level and number of stakeholders in achieving the outcome and recognizing each stakeholder's contribution to that outcome, which includes not just government as well as NGOs that might be involved, but also community and private sector that might be in that area. Even though it takes a little bit more effort that's not specifically around technical interventions, the ability to sustain that momentum to continue is a tremendous benefit. And I do also agree that it's a challenging it's a challenge because it's not specific. The way we work doesn't always fit into boxes. It's more around how many cups of tea we have to make things work and to sustain it over time. It's building relationships. Yes, I wanted to say that it's difficult to leverage the investments that are required, the sustained investments to sustain the level of long-term investment that's required to achieve and demonstrate that quality can be achieved.
Thank you. Andres?
Thanks, Mark. And for us, it's our guiding point is the patient. And so if we look at patient as well, patient lives longer. We're a for-profit impact corporation, but at the end of the day, that's a way that we stay on board. Patients less complicated, it costs us less. And so when we look at leveraging our infrastructure, first I'd like to mention our home dialysis program, where we've been able to extend. If you look at a clinic, let's say with 12 or 20 chairs that has several consult offices, that's a fixed capacity that we have in terms of patients having to get on a bus, having to go get on transport, and that's an issue. Aligning to the patient, home dialysis, they only have to come once a month. We can do telemedicine to look at their evolution, and it all of a sudden expands a much greater radius. And really, when we looked at our Check Your Kidney program, that's a great way for us to also leverage, because we've got nurses, we've got general practitioners, we already have some of these tools that we use on a day-to-day basis. And so it really has been magical in terms of how keeping that simple formula of making sure that everything is aligned with the patient, safety, experience, clinical results, and then the economics sort of follow as a result.
Yeah. And Monisha, I'm not sure if you've got anything you'd like to add on this.
Yes, can you hear me okay now?
Yep, keep that microphone close. Thank you.
Great. I think the only other thing I would add is in terms of leveraging investments and infrastructure is also taking advantage of the digital platforms and systems that are being developed. I think this is a big game changer in terms of how many new digital tools are available for data collection, for tracking patients over time, for being able to communicate with patients across care settings, et cetera. And so, for example, CII works with a group called Simprints, which is using biometric IDs to be able to track patients and the care that they're getting. So I think there's a lot that we can do in terms of leveraging digital and data systems more effectively. And CII has been supporting developing a digital health vision and in line with the principles of donor alignment for digital health. And so applying some of those best practices in terms of leveraging software for public goods and other tools like that could help usher in more of this value-based care transformation.
Great, thanks, Monisha. And I want to get to weave in a couple of questions from our participants today on this topic of data and analytics. One version of this for Sunil is a question related to the extent to which new kinds of data scientists are needed, and is that a capacity constraint in implementing these models at scale to bring the data together, to clean it enough to support the analytics that you need for the model to work?
Yeah, thanks for that question. I think that's an excellent question. So there's a problem when you look at data in developing countries, especially in healthcare. There are problems, challenges at both ends of the spectrum. So on the one hand, in terms of availability of data, even though all governments collect lots of data, the challenge is that in most developing countries, The quality of the data is extremely poor. There are large gaps in the data, so that in many, and also it's very fragmented. So most governments in developing countries have multiple data systems within healthcare which are not integrated. So net getting data that's usable in terms of quality, in terms of volume, etc., is really challenging. Second issue is that even when you find decent databases within government in developing countries, very often, even though they may trust you and your organization, governments are understandably so cautious about sharing data, because of concerns about patient confidentiality and privacy and so on, that even getting access to that data takes a long amount of time. Then at the other end, exactly as the question says, there's the challenge of unavailability of data scientists. So in a country, to produce data scientists, you basically need lots of master's programs in data science. And to give you an example, in all of India, with 1.3 billion people, as of a few months ago, there was just one master's degree program in the entire country issuing degrees in data science. So there's a huge shortage of data scientists, which is going to create an issue in the future if we don't start producing them. There's a lack of, data governance standards, which are typically issued by government, so that there's a framework on how to actually use data, healthcare data, effectively. And then there's the issue of actually the data sets themselves. So the good news is that many developing countries are now appreciating that this is a challenge. So in India, as an example, the government is working very rapidly on developing a national data health blueprint, which will incorporate data governance standards, incorporate things to maintain data privacy and confidentiality for patients and so on. And at the same time, we're working with the government of India to try and increase the academic and research ecosystem for data scientists, so that 5 years and 10 years from now, we can have tens of thousands of data scientists rather than only dozens or hundreds. So these are challenging issues, but we are making progress. And hopefully in the coming 3 to 5 years, we will be able to accelerate this progress.
Great. Thanks, Anil. And then a related question, I think maybe I'll start with Monisha on this one, that highlights that in all of these kind of value-based programs, it's beyond the data challenges, it's creating metrics to drive action and to drive accountability and connections to payment as well. And I get this question a lot, but for maybe Monisha to start, it seems like for the reasons that Sunil described, it may be difficult to construct these measures in a meaningful and reliable way that account for differences in health risk, that account for potential biases if these measures actually matter for payment or accountability and misrepresentation and the like. Can you talk a little bit about your experience and what it takes to get to meaningful measures, and appreciate any brief comments from the other panelists too.
Great, thanks, Mark. I think that's an important question and central to trying to design effective value-based care systems. I don't think that we fully have an answer to that, and I think it takes more experimentation at a local level to see how to best design those metrics, and whether they need to be locally designed in every context, or whether there's some that can be extrapolated to regional or even global metrics. And I think we can start simple, right? So instead of starting with a complex set of metrics, pick like 2 to 3 metrics that really focus on patient satisfaction and patient well-being, asking what is it that patients care about, and we have plenty of experience with designing surveys, and there are a lot of groups that are already starting to use more metrics for satisfaction and well-being, and incorporating that into how providers look at data and how they can adapt their care. And then in terms of the financial incentives, I agree that it can be difficult and could be convoluted to start with aligning financial payments to these metrics. And so it takes time for the providers to get comfortable just with measuring metrics, measuring value, and getting the providers to practice, looking at that data and adapting care accordingly, and not introducing any financial incentive right away. And then even when we start with incentives, we could start with non-financial incentives around like more positive rewards, recognition, peer group support. There's many ways in which we can incentivize providers, especially tapping into that intrinsic motivation that many providers do have. And then only eventually, and if it is appropriate in that context, then to think about what are the financial rewards that could be aligned to those metrics. So I wouldn't start with that. Yeah, so I think we definitely need more experimentation to learn more.
Okay, great. Thank you. We've actually got more questions. Krishna, I did want to do a time check. Do we have much more time for discussion of these really interesting topics?
Or maybe one more question and probably 2 minutes till we need to move on.
Okay, well, maybe I'll shift gears a little bit and put a couple of questions together. There were several questions that basically amounted to, well, working with governments on value-based care is hard. So is this more of a middle and high income country phenomenon? I'd say it's hard in the higher income countries as well. Sunil, I think you emphasized some of the challenges in working with government. So there's some comments along the lines of, well, is it possible to do this outside of government, maybe working with the private sector or other sources of financial sustainability? Maybe for just final wrap-up comments from each of you, just a brief comment on how to make these models work with governments in low and middle income countries. And Sunil, do you want to start?
Sure, perhaps I'll kick this off. So two things. So although it is challenging working with government, but it can be done. And you just have to go in with the right mindset that it'll take time. It can be frustrating at times, but then you achieve scale. For trying to operate and to develop scale without working with government, to me, that's in some ways even more challenging. And I've seen multiple experiments, both in India as well as in other developing countries, where there are really interesting models for providing primary care, technology-enabled primary care in many cases. But I have yet to see, any models that have really scaled up to the point of serving hundreds of thousands of people or millions of patients, etc., purely in a private sector ecosystem. And the reason is when you get into providing healthcare services to the true bottom of the pyramid, so even within low and middle income countries, when we're trying to address the needs of very low income communities that are earning, let's say, less than $1 a day, just the ability to pay for these kinds of healthcare services becomes challenging. And then when you consider the costs of operating in these areas, which in many ways are more expensive than operating in urban areas because access is difficult, there are power outages, water shortages, internet connectivity issues, etc. So when you take into account all the additional costs, the personnel challenges of trying to get people out in scale, meaning medical personnel to provide services in these remote and low-income areas, it becomes very challenging. So like I said, I've seen multiple examples, but I haven't seen too many that have really been able to scale up. On the other hand, I have seen many examples of primary care delivery models that have scaled up in partnership with government. So in Liberia, there's a wonderful model called Last Mile Health. I mean, I could give you several names in different countries, but partnering with government for this, providing care services in really low income communities, partnership with government seems to be the way to achieve both scale and long-term sustainability.
Thank you.
I'd love to hear from the other panelists about this.
Geeta, any final brief comments on this?
I think that the national governments in most countries where we work have frameworks and policies that incorporate quality, universal coverage, and cost efficiency. So when designing and implementing the programs, if we can connect what we do in partnership with government or with local non-governmental entities to these national well-laid plans that are short of being fully operational, and then reinforcing the achievement as something that is part of the government system, however small or great these achievements might be, goes a long way to pushing out the momentum towards a value-based care goal. And one more comment before I switch is related to the data and the importance of data. I think that the biggest gap, and I think that data use and data can drive this momentum towards achieving our goals in value-based care, but that the biggest gap is actually not in data scientists who know how to manage the data and to analyze the data, but in the visualization of data and the communication of data, such that the data use can be optimized at all levels, from even the household and community level all the way up to the policy level for decisions, in that it's reliable, it's rapid, and is very relevant to making decisions, ongoing decisions.
Great. Thanks very much, Geeta. Andres, final comment on this?
Sure. So two things. One is the data, and then the second thing is the value-based in collaboration with, let's say, the government. I'll start with that one. We, for a number of years, we've had the honor of working for different levels of the Mexican government, and I have to say that it's a challenge because first of all, they have a lot of different priorities. We're in specialty care, which certainly is an expensive part, and there's an elephant in the room, at least in the Mexican context, which has been corruption, which has been sometimes things that take us away from really the point at hand, which is taking care of the patients. And so when we've tried to put in value-based care or even remote measures of quality, it becomes very, very difficult because a lot of the mindset is really transactional, and because that's at the end of the day what can be more immediately measured. Which going on to the second part, from a data science perspective, we're a small company. We've got about 300 professionals, and we do have a data science area, which has been very critical, of course, coming out of our electronic system. Monisha talked about the technology, and so there's certainly a lot of inputs there that we can take. And so we've built them around the patient, certainly the livelihood, the morbidity events, and then really the channel and connecting the dots of the basics in terms of the patient outcomes. You mentioned, Mark, the ability to have transparency, the ability to have accountability. A lot of that is also even for us. And so for us, in terms of linking specific an infection to a specific machine or perhaps to a specific professional, that can be difficult, but that's something that having the data and understanding it is very important. And last piece there is that it's sometimes very easy when you're collecting 1,000 metrics to get lost in the data, kind of like in baseball or in any sport. You sometimes got to go back to that top score, which is, are our patients living longer and are they happier?
Great, thanks. And Monisha, any final quick comment?
I think the last thing to close, completely agree with Sunil and Geeta and Andres on all of this, is from the thinking about it from the patient's perspective of what is their continuity of care, what's their care pathway for a particular episode, right? They're going to go to a public clinic and then maybe go to a private clinic if things get serious, you know, and then maybe they have to go back to a public hospital. And so they're going to be going across care settings and across time. And so how can we coordinate better across sectors and across care settings, and leveraging data and digital tools to maybe better able to track patients along a care pathway, so that we can think about how to provide better care holistically to them. So I think there's definitely an important role to collaborate with the public sector, given there's linkages across that care pathway. And I think there's a lot of innovators out there that are already starting to do this, and so would like to love to collaborate and see how we can support and scale up those innovative models in value-based care. Thank you, Mark.
Great. Thanks. Great point to end on. I want to thank you all for your leadership and for your participation in this Innovations in Health Network. I think we're seeing, while getting to high value primary care as part of a more integrated, as you were saying, Monisha, healthcare system is challenging, but lots of great ideas and evidence that it can be done. So look forward to continuing these efforts together. I wish Zoom had an applause function. That's one thing I think is missing when we do these virtual models, but thank you all very much. And let me turn this back over to Krishna.
Fantastic. Thank you all. And I certainly applaud the amazing work that you're all doing, as well as the depth and nuance of the discussion. Thank you all also for jumping in and making this just a great digital panel. We've had less than a week to make it work, but you guys have all helped us pull it off. And special thanks, Mark, to you for the great job as always in moderating and tying together lots of different threads to make this a cohesive conversation. So always much appreciated.